Wednesday night. Wednesday, of course, means practice KFP time. I'm Kane Treble. And for those of you who have just found out the results for the 2023.2 CCE exam, congratulations, and hopefully it was everything you were hoping for. 85% pass rate, which is just fantastic to see. Of course, tonight we are going to focus in on the KFP exam for 2024.1. It is just before Christmas, and so I appreciate our numbers may be less than usual tonight. Fair enough. And we will be taking next week off as well, so there'll be something put up, shall we say, a nice little treat for people. But, of course, without further ado, we need to be concentrating on what we are here for tonight, and that is, of course, preparing ourselves for the KFP exam. So, we are 45 days before the exam, which may seem like the clock is ticking faster than perhaps you are feeling ready for, but rest assured that there's still plenty of time to be preparing yourself for the exam. The question is, of course, what are you doing? What should you be doing? And step one, which isn't on this list here, is you should be looking after yourself. You should be taking a bit of time. It's the end of the year. It's always a bit of a crazy season. I want you to be making sure you're spending some time on Christmas with family, whatever kind of celebrations you have at this time of year. I want you to focus in on that for at least a couple of weeks. Once, of course, we are back into exam mode after New Year's, I want you to have head down, bum up, and really smashing through. What I hope you're doing by that point, once you do restart, is I want to make sure that you are fully comfortable with the exam format and the requirements there. I want you to have completed your study syllabus. I want you to have covered all the things you want to cover, because now is not the time to be trying to learn new things. Don't freak out. Don't freak out. I know that sounds scary. Rest assured, all is well. What I mean by that is I don't want you to be sitting there trying to do rote learning through textbooks, trying to cram stuff in. Time has passed. that is okay. You're still going to have plenty of time to learn things, but that shouldn't be your focus. I want you to be refining your time management skills, to master the case analysis, to refine your critical appraisal, and of course, practice, practice, practice. Let's spend a bit of time going through these here. So with the exam format and the requirements, first and foremost, I want you to really appreciate this is a handwritten exam. So if you're spending most of your time practicing questions on a computer, that's fine, but I really want you to spend this next 45 days handwriting out your answers. 1 line, 1 mark, 1 answer. Okay, there's potentially 2 or 3 marks there, but I really want you to get into that habit of making sure you're being concise and you're setting yourself up to succeed. They give you enough lines for the number of responses they want, and so if you're going over that or under that, that should be your first little cue that you're doing something maybe not wrong, but different than they'd intended. I want you to also have practiced using the MCQ answer sheets. By now, they should be sending out some of the practice exams, and I want you to be practicing on those, how to answer in that format, and in particular, what to do when you're not confident or want to change your answer. How do you do that? I want you to have nailed that format by now. And of course, it sounds silly, practice your handwriting. The number of people that come out of the KFP exam complaining of hand cramps and sore hands from having to write for so long is, yeah, it's a thing. So practice, 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 handwriting, and of course, no abbreviations. Yeah, you might get away with 1 or 2 if they're particularly common, but break that habit now. And for tonight, any answers you put down, I want you to make sure you're not using any abbreviations. We need to really nail this home. If you want to potentially miss out on marks, go ahead, use them to your heart's content. But if you want to smash this exam, no abbreviations. Now, again, as I said, I don't want you to be using this time left to try and learn new things. I want you to practice questions as broad across as many sources as you can, and I want you to try and start to pick up what are your weak areas, what are the areas that you need to be focusing in on that you're not getting the marks you want to be doing. Of course, I'll be putting up regular questions all the time, but if you're trying to find more practice questions, GP Academy, ModMed and KFP Bank are my current recommendations. I know there's others out there. These are just the ones I've had personal experience with and that I would recommend as being pretty good and pretty accurate towards what the actual exam is. So pending further information, this is where I'd stick to. Now, as we do in here, I want you to be practicing to spend about 2 minutes per question. Practice reviewing and revising questions as well, and if you sit down to do any practice exams, I want you to be actually spending that time at the end, actually going through and looking at, well, how are you revising your questions? What is your flag technique? How are you going to flag questions for later that either you're not confident in your answer, you don't have an answer, or you want to go back and look at further details. If you're spending more than that 2 minutes per question, you probably do need to be moving on, but set up now what technique you want to use to flag that. It could be a note on your paper, it could be turning a corner of the page. Try and think of now what you want to do to make sure that you don't miss out on that. Every year I hear stories of people who have marked a question as come back later, and for whatever reason, they've never actually made it back. So please don't let that become you. Make sure you have a way to know which questions you need to be returning to. And of course, master the case analysis. I want you to be writing out clinical summaries. I want you to be really nailing that and getting a clear view for each question, each case. Who is that patient sitting in front of you on the page? You know, not really sitting in front of you. I get it. Okay, yeah, sure. But I want you to have that clear picture of who is that patient, because that is what they're examining with the KFP. And of course, tied into that as well, make sure you're answering the question that is being asked. Hint, hint, wink, wink, might be a few cases of that tonight. Let's find out. Refine your critical appraisal, and the easiest way to do this, vary the STEM. Once you've sat down to do an exam, or if you have a cache of exam questions that you've already gone through, change features in the STEM. Ask yourself, how does that change my responses? Vary the question. Change it from a non-pharmacological to pharmacological. What does that do to your answers as well? Use these things to multiply the number of cases you have access to. And of course, practice, 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 practice. Are you picking up on some kind of theme here? This is what I want you to be focusing in on for the next little bit of time. I want you to be getting as much time in practicing cases, identifying your weak spots and honing your techniques. This is the time to hit crunch. All right. Now, hopefully that all makes sense. Hopefully you have gained something from that there. But of course, tonight we are here to practice some more questions. So we've got some up on the clock. You may have noticed I'm trying a few different things out with the graphics tonight. Hopefully it works. If not, let me know. Put something in the chat or leave a comment later. Let's get 2 minutes on the clock and your time starts now. All right, so time is up, and sometimes these questions come along that you feel like they're almost throwaway questions. They seem a little bit too easy. I'm not trying to trick you up tonight. Every now and then you will get some easy ones thrown your way, and of course here we've got a wide range of differentials you could be kind of going into. I think though we want to look at that qualifier there in terms of what is the most likely diagnosis for ROSA. So with sudden onset of kind of acute pain, the things you'd be wanting to really kind of rule out and are the most likely in this setting would be things like deep venous thrombosis of the right leg or calf. I think either way, if you specify that, you're going to get 2 marks there. Now again, we are being specific and concise, and so we want to be specifying this is of the right leg / calf, whatever you want to put in there. If you're just putting in deep venous thrombosis, you're going to be missing out on potential marks. Likewise, if you just put DVT, you're again using an abbreviation as we've gone through, you're going to miss out on marks there. So again, avoid all abbreviations. Hopefully I'm really ramming that home. Sorry if I'm driving you crazy with it. Now, of course, there's also these other reports here of this bit of fatigue more than usual, no other specific symptoms. This should raise some red flags for things like a pathological fracture of the leg or calf. And again, if we're being right leg or calf, being specific there, you'd be getting 4 marks. Otherwise, the less specific you are, you're going to be potentially losing out on marks. And of course, this is most likely diagnosis. You'd be thinking about things like acute cellulitis of the right leg or calf. Now, with these vague non-specific things, you would also consider things like compartment syndrome of the right leg or calf. In here, I think there's a few too many red flags to say simple musculoskeletal, there's no preceding trauma, and so I don't think you would actually be getting any marks by putting that one in the differential list here. All right. Of course, we have more questions to go through. Let's get another 2 minutes up on the clock, and your time starts now. All right, time is up, and of course, the people watching and waiting may have noticed. I mucked up the units of measurement. Sorry, but we know a hemoglobin of 90 is definitely on the lower side. Apologies for that. Now, of course, this does take this case towards a slightly more kind of sinister turn, and with this, we should really be starting to think of malignant causes, and in this case, really, it's trying to lead you down a situation of lytic lesions with myeloma being one of the leading culprits here. So for this, you'd be ordering a SPEP, serum protein electrophoresis, X-ray or CT skeletal survey. Now, with that, I think you would get full marks either way, but I do want to point out this is set in a rural general practice, and so taking that into consideration, not every rural town has ready access to a CT scanner, which is why I think getting the X-ray marks in there would definitely be valid. Certainly, kind of gold standard would be CT skeletal survey, and it is likely that that would be available in some way, shape or form. And certainly the question does specify what investigations would confirm the diagnosis, and so that would be where we'd go. More on that in a moment. Of course, we would be looking for a bone marrow aspirate and biopsy, and this would likely require referral to somewhere else to have it performed. Again, this is what would confirm the diagnosis for Rosa, and so that's going to be kind of on that list still. Now, the positron emission tomography, for this one, I have marked it down there as a little bit of a risky answer. The reason for that being, yes, it would be diagnostic, but it's usually not done first instance. This is usually done as a follow-up thing to track either progress, complete staging, or to check response to treatment. So again, if we're saying to confirm the diagnosis, I don't know if this would necessarily be put out as a first line kind of thing there. Hopefully that makes sense. Now, the thing with the PET scan is it is more sensitive than conventional skeletal survey for detection of osteolytic lesions. We do have the options as well, things like serum or urine immunofixation, so that's identifying paraprotein immunoglobulin types, and should be considered as well negative in patients that have non-secretory multiple myeloma, and so you may actually miss a few diagnoses there, but certainly would be part of a workup. So lots of things to keep in mind there, and hopefully you've managed to get a few of those down. Of course, we have another question. Of course we do. Let's put 2 minutes back on the clock, and your time starts now. All right, time is up, and you will find questions like this from time to time where it's checking some of those softer skills, those communication skills that go along with day-to-day general practice. Now, as part of the curriculum in the 2016 curriculum guide, they do mention they love the spikes mnemonic. It is also mentioned in the 2022 revision curriculum, but not as specifically stated, more points towards articles that spell out the mnemonic. And so this type of question is something I have seen before in actual exams. I obviously can't say what the exact question was, but suffice to say I would never be surprised to see this in an exam as well. This is also something that we do day to day, and so even if you're not sure of any particular mnemonic or thing that they would be looking for, having a bit of a common sense approach I think would still score you reasonable marks. Now the spikes mnemonic is of course S for setting the scene, or some kind of equivalent kind of answer in that form guiding to that statement. Perception, so establish the patient perception or knowledge base from which to build upon, would be another mark. The invitation, I for invitation, to explore what the patient wishes to know or equivalent. Knowledge transfer, so direct and simple knowledge transfer using non-jargon and making sure the patient understands the information as it's given. And to recognise or empathise, E for empathise with the patient emotions. Multiple mnemonics will kind of flick between empathise and emotions, again as long as you're having something in there, and of course summarise the consultation or have that strategy for moving forward. So something to say, this is where we're at, this is where we need to be, and this is how we're going to get there. Hopefully something you've seen, heard and practiced before. Hopefully it's not something you've had to practice because it's a horrible thing to have to go through, I'm very sorry, but it is a handy skill to keep in your GP toolkit. Alright, we have another case ready. Let's get 2 minutes back on the clock and your time starts now. All right, time is up, and let's have a look at some of the answers. This is checking your awareness of what are the risk factors, the physiological risk factors for erectile dysfunction in a middle-aged male. So certainly coronary or peripheral artery disease, some form of arterial disease is definitely going to get you marks. And he's in that age bracket. History of hypertension, these are things you're going to come across as not uncommon causes. Of course, we also have alcohol use, which is certainly known to heighten erectile dysfunction. History of hypertension as well is a massive risk factor. There's a positive smoking history. Smoking also strongly correlates to rates and severity of erectile dysfunction, as does hyperlipidemia, dyslipidemia. Now, here it's not explicitly stated that he has hyperlipidemia, but again, we're talking about potential physiological conditions or risks here. Likewise, diabetes mellitus, there's no other real indications that that's the case, but if we're talking about risks, and tied into that as well would be metabolic syndrome. Now, of course, cause for concern would be neurological disease, or if they name a specific suitable example or condition, spinal cord lesion or injury. Again, there's nothing in this case to say that could be the case, but would be something you would have to keep in the back of your mind. Peyronie's disease as well, so abnormal curvature of the penis can result in erectile dysfunction. There's again nothing in here that would specify if that's the case. It would be perhaps a little bit unusual for it to be presenting so late in life, but certainly not possible. And I would say that's probably a little bit of a risky answer, given they've actually specified here no abnormalities are noted during a physical examination. Now, antihypertensive use, just the simple fact that he's taking perindopril. Perindopril and most antihypertensives can have can cause erectile dysfunction. And you may want to, presuming all the numbers are relatively behaving themselves, consider a trial of cessation to see if that doesn't improve his situation. Now, things like anti-androgen agent use, here it's explicitly stated that he's not taking any other medications, and so you wouldn't get marks for that. Likewise, antidepressant use would not be getting you marks, and hypogonadism would not also be getting you marks. There's nothing to indicate that's ever been a cause, and would be very unlikely in this situation, therefore. All right, hopefully that makes sense. Hopefully you've scored some answers here. Again, many more causes than there are requests for potential answers. And so if you ever get stuck in these things, again, go back to the vitamins mnemonic, or try and think through from first principles, what are the systems involved and what can go wrong with them. We have another question, of course. So let's get 2 minutes on the clock, and your time starts now. And time is up. Now, this is one of those things that is, I think, incredibly common, and we probably don't acknowledge as well as we could, the psychological or emotional factors that do factor into erectile dysfunction. Now, there's potential things here for sure, things like stress, very, very potent depressing factor for... You know what I'm trying to say. Stress can definitely lead to cases of erectile dysfunction, and mentioned here specifically is Malik appears anxious, and you would have to consider a diagnosis of anxiety contributing to his erectile dysfunction. Likewise, things like depression definitely strongly correlates to not only decreased libido but also erectile dysfunction, and something you would want to explore would be any relationship problems. Now, of course, the other thing that needs to be taken into consideration would be low self-esteem. If there's things that have him feeling particularly low about himself, that's definitely going to impact on his sexual performance. So again, many more causes than requested answers, and so as long as you're putting down some sensible kind of things, I think you're going to be getting lots of marks for this one. All right, of course, one more question for this case, so let's get another 2 minutes on the clock, and your time starts now. And time is up, of course. We have some answers for you. And this is one of those things I think that the knee-jerk reaction for a lot of clinicians is to say, we've got all these new tablets here, try them out. And often that does get people through rough patches. But there are heaps of other tools that I would implore you to consider using if you have any cases of erectile dysfunction that meet you in your rooms. Now, of course, referral to a psychologist for cognitive behavioural therapy is definitely going to be getting you marks here, and exploring those underlying psychological causes for erectile dysfunction. If there are couples issues or it's a performance anxiety, often referral to a sex counsellor for specific sex therapy can work absolute wonders, and tied into that as well would be couples therapy along that line. Now, if they're seeking mechanical assistance, you can look at vacuum erection devices. Again, non-pharmacological, so would definitely score you points here. We also know that looking after your general health and well-being can have profound impact on things like erectile dysfunction through reversal of a lot of those risk factors we talked about earlier. So things like regular moderate intensity exercise, 30 minutes per day, at least 5 days per week, maintaining a healthy body mass index under 30. In that as well, I think you would also probably get marks if you mention decreasing or completely cutting out alcohol intake, and of course smoking cessation. Not on this list, but definitely should be. Of course, ensuring adequate sleep. So we know that people that are insomniacs or don't get sufficient sleep are much more prone to experience erectile dysfunction, which often is improved or completely restored following adequate sleep hygiene measures and adequate sleep levels. Now, if you want to go to the real, I was going to say pointy end of the stick, maybe not the best thing to say in this particular case. But if you want to go to the more kind of extreme management options here, non-pharmacological, you would be looking at things like penile implants or prostheses to aid. I'd probably be exploring some of the other things first. Just my personal opinion. Now, something that isn't in this list because it is pharmacological, but I wanted to just mention it briefly, is something I found quite useful for a lot of patients is to offer them that safety script. So offer them a script for sildenafil or any of those kinds of medications, and just let them know that they might not actually need it. But sometimes just knowing there's a backup plan there, that if they feel like they can't achieve an erection or sustain an erection, there's something that means they can have another crack in half an hour, or however, whatever time frame it may be for whatever you prescribe them, takes that pressure off them, and they can then have successful intercourse or relations without actually needing to take anything, just by knowing that there is that backup plan in place. And I'm completely upfront that is exactly why I'm giving it. And yeah, I've had massive success with patients coming back to say that worked an absolute treat. Thank you very much. Something to consider. All right, we have another case. We have more questions. So let's get 2 minutes on the clock, and your time starts now. All right, so time is up, and I think just about every practice exam, every exam I've seen has some kind of question around menopause. So this is a topic the college really wants you to absolutely ace and know like the back of your hand. So, of course, what are the benefits of menopausal hormone therapy? So MHT is the replacement term for HRT. For a woman like Emily, here they're asking for 3 things. We've got many more than that. So, relief from hot flushes, relief from night sweats, relief from sleep difficulties, lowered risk of osteoporosis. And here's where reading the question comes in handy, because yes, there's things like improvement in mood and improvement in vaginal dryness or dyspareunia, but these are things that are said, what additional potential benefits? And so given she's already specified that she's experienced those things, but they're now well managed, you would not be getting marks for those. So again, even though this is a almost kind of free marks kind of question, always make sure you're not falling for any traps or any misdirections, shall we say, to get those marks there. Hopefully you did well. Let's get 2 minutes back on the clock for the next question, and your time starts now. And time is up. Of course, we have answers here for you, and of course, the ones we're all going to know about: increased risk of blood clots or deep venous thrombosis. Definitely going to score your marks. There is a slight increased risk of breast cancer, but certainly nowhere near what was stated from earlier studies, which were on markedly older populations using different hormones at very different concentrations, much higher than what we use these days. Now, there is a slight increase in the risk of stroke, and again, the further from menopause you are, the greater this risk is. There is an increased risk of endometrial cancer with estrogen alone therapy, which is why you would have to note that yes, this is estrogen therapy, but we are combining it with a progestogen for that protective factor. And as well, something that I think is really worth noting is that in most cases the risks are outweighed by benefits if commenced within 10 years of menopause. I think that's something that is, in terms of the important risk or side effects, this is still something that I think would get your mark because it's important information to convey around these risks and side effects. Hopefully that makes sense. Of course, we are almost at the end of tonight. We still have a question to go. If you want more information around these things as well, I would really, really encourage you to check out the Australasian Menopause Society, which have some absolutely fantastic information there. Of course, I know a lot of people also use the Jean Hales website, which I think is probably a little bit more patient-friendly, covers many more topics outside of just menopause. And so if you have a patient that might particularly browse things around and you send them there for information around menopause, but on the way they happen to find out a bunch of other things that could be beneficial to their life, win-win. But certainly straight to the source here is the Australian Menopause Society, so Australasian, I should say, Australasian Menopause Society. They also do have some great handouts which print out quite well, and for that, hey, we've talked about a lot today, here's something to take home and read through. I use all the time. All right, last question. Let's put 2 minutes on the clock, and your time starts now. All right, time is up. And again, this is one of those questions that has a lot of people licking their lips over things they could do. And of course, preventative health is a GP's bread and butter. So things that you could be taking the opportunity to do that are going to give you more marks would be things like encouraging to complete a fecal occult blood test to screen for colorectal cancer. 2 marks, boom. Encouraging cervical screening if due. 2 marks, boom. Encouraging mammogram to screen for breast cancer, 2 marks. Clinical assessment for risk factors for osteoporosis, 2 marks. These are all those big ticket items that come straight from the RACGP Red Book, preventative health measures in general practice. Now, you will note though, these things are worth 2 marks because they are those big ticket items that you really want to make sure someone that's coming into 50 years of age should be having done. Of course, you've got your more bread and butter day-to-day things that would get you some marks, things like measuring blood pressure, ensuring immunisations are up to date, reviewing smoking history, alcohol history, review cholesterol and other lipids, review OSDRISC, inquire about stroke or TIA symptoms, raise awareness of early signs of skin cancer, visual acuity changes, glaucoma risk, review height and weight. Yes, they're also in the Red Book, also in the recommendations for what we should be doing. But I think this is where actually showing that consultant level understanding, consultant level knowledge of, these are all things that we could do, they're potential answers, but where are you going to weight your effort, your time? What are the things that are going to be best suited to help this patient sitting in front of you? So yes, it's good to check their blood pressure, do all those other things, but you have entered them into that age bracket where you can start to do all of these fantastic screening programs that could set them up for the rest of their lives. So again, you would get more mark for those, and that's where you would focus in on your answers. Now, tied into that here, this is a question that at face value seems very, very simple. But if you notice here, we've got multiple things that are worth 2 marks and lots more that are worth 1 mark. And so you might get valid answers for every single one of these questions, but miss out on almost half of the marks for the question because you haven't shown that prioritisation of what's really important for this patient here. And I think this is one of those questions that you go through the exam and you think, yep, I absolutely smashed it, did well, I'm very happy with it, but you may not have given them what exactly they were looking for. So look at that STEM, look at that patient, picture that patient in your clinic and think, what would I do if this was the patient sitting in front of me? Tailor your answers towards that, because that is at the end of the day what they're really trying to assess with the KFP. And I thought I'd end on that little bombshell tonight. Hopefully you've done well there. Well done for making it through yet another Wednesday night. I appreciate you've probably got other things you want to be doing on these nights, but you should be very proud of yourself for sticking through and mastering the KFP. Of course, I will be continuing these live streams leading up to the exam. If you would like to spread the word, it'd be greatly appreciated. Like and subscribe, all the usual YouTube garbage that I probably should be saying, but anyway. Admittedly, knowing that there's subscribers and view counts and things lets me know that people are finding this helpful and encourages me to continue making them. So if you wouldn't mind, telling other people that are studying for the KFP about this would be greatly appreciated. Now, of course, we will be having next week off. It will be the Wednesday between Christmas and New Year's. I hope you don't mind. I'm sorry. I've got 2 boys. I've got a wife. I have somewhat of a life, I guess, I hope. And so I will be spending it with them. And I encourage you to do the same. Have a Wednesday off. Have a week off from study. I know you're probably getting very stressed, but sometimes you need to look after yourself first to make sure that you're going to be hitting the ground running and really getting into that last few weeks before the exam to give you the best chance possible. Now, with that all out of the way, I hope you have had a great week. I want to say as well that these are very stressful times for GPs in Australia, and you are a part of a team of people that are trying to do what we can to make this world a better place. And you should be proud of that. I know that it's something that doesn't get appreciated necessarily from many sources, and particularly with the media at the moment, there's a lot of negativity around general practice. But the fact that you're here at 9:15 on a Wednesday night going through exam questions shows just what a fantastic doctor you are and how far you will go to look after your patients. So big pat on the back, have a week off, rest up, enjoy life, see family, have fun, dare I say, and I will see you the Wednesday after that, which will be, let me just confirm the date before I say it, the third Wednesday, the 3rd of January 2024. Until then, good night.